It is a privilege to open this symposium, the Netherlands Cancer Registry in Europe, and to warmly welcome you at the other side. You know, cancer registries play a crucial role in cancer control, and we have the chance to underline this in this symposium. We really have a great program, and we will take you on a journey from the patient's voice, a global view. We'll go to Europe, and then we'll zoom in into the Netherlands and the Nordic countries to give you some examples. And we will end up with a panel discussion on how data could help us to be ready for the challenges in the future, because that is what we are looking at, the future. I also want to invite you, please, if you have a question, don't hesitate and put it in the chat box in your system. Oh yes, you're probably wondering why a Belgian girl sits here in front of you for this symposium. And if you would ask that to a Dutch chair, probably he or she would quickly answer, yes, because we are the best. I will not answer that question until the end of the program for me, because we know the Belgians and the Dutch people, we really have many similarities, like the traffic jam, like the COVID-19 problems, the vaccination, the cows and the milk and the cheese with the registries, remember, the trees? But we also have differences in football, in hockey, in ice skating, and we have a government in Belgium. But tonight, it's cancer registration that really unites us. And I promise to answer that question about the Belgian girl at the end of the meeting. It is really a pleasure to introduce the first voice of this evening. And it's important that's the first voice because it's the voice of the patient and the patient perspective. And I'm really happy that Robert Green is here with us. He's patient advocate as board member of the European Cancer Patient Coalition, but he is also the founder, because he wants to do something, of the Hunger and Thirst organization. But above all, he is for this night the expert by experience for us. So Robert, very welcome in this symposium. You kindly accepted to answer some of our questions. And in view of the title of this symposium, I really have a burning question, because patients and you, did you know about the cancer registry? How?
Well, first of all, thank you very much. And I must say, I try my best to represent patients, but of course I will never be able to represent all patients. So it is an honor to be here and try and answer some of the questions. Well, to be very honest, the cancer registration, I know about it because of the data that I often see, but I've never dived into what exactly it is, how it looks, how it works, etc., and what benefits us as patients.
So that means that you're triggering already one question about the visibility of the cancer registries and the statistics. What do statistics tell you when you are in front of the physician and when he, let's say, presents you some data? What do you do with it?
Well, there's always one burning question that I ask, and I also stimulate other patients or citizens to ask, what does it do for me? So the same goes for the cancer registry. What does it do for me as a patient, or what does it do for us as patients? So that is the first burning question that I would have.
That you would have?
Yes.
Of course. You know that the Netherlands Cancer Registry, they have a quite good reputation. And I think that you have participated a bit this afternoon when we were speaking about the patient-reported outcome measures and also the patient-reported experience measures. And I think because we had a thoughtful conversation between the two of us, and you made some allusions to that. What could it do?
Well, thanks for remembering that. One of the things that I actually find quite important when it comes to PROMS, patient-reported outcomes, and also patient-reported experience outcomes or measures, I question, and I also say, it is all after the deed is done. So the reports, for me, says something about my past. And what I would really love to see, and I'm not a scientist, I'm not a researcher, but what I would really love to see is how can we use the anticipation that patients have, the expectations that they have, and work on those and see how we can actually increase and have a more positive effect on the outcomes. So then after when the deeds are done, most likely we will be able to have satisfied the patient even more.
So we have to come up more early then with presenting, for example, the results of such a kind of patient-reported outcomes to the patient, even when discussing therapy, diagnosis. Is it that what you are suggesting?
Well, it is definitely, I think it can be part of the solution. What I want to know is that the data that has been collected, I want to really feel that when I get the diagnosis of cancer, that I feel that I can put it to good use and that it will most likely and hopefully affect the quality of life that I'm actually looking forward to.
That means that physicians and patients really do need an in-depth conversation. Could you suggest something about time to spend?
That is a very good question. Time to spend, it makes me think right away about a more patient-centric and patient-centered approach. So I will not say that every patient requires 50 minutes or 20 minutes or 30 minutes. I think that it's very important. If we want to have a patient-centric and patient-centered approach, we need to be able, and physicians and healthcare professionals need to look at the specific patient also and try and figure out as soon as possible what the specific requests are. And depending on that, we can then move on and see how much time we need to spend. But I know it's easier said than done. But if we want to improve quality of life for all the patients coming after me, we need to be innovative and we need to spend time and continuously try and find solutions for these problems or challenges.
And how collaborate together? Because we have the IKNL, we have the physicians organization, the scientific organizations. How could we improve, for example, the communication about patient-reported outcome? How could we do that?
Well, I think collaboration is always a big challenge. It's a challenge within the healthcare professional, but outside of the healthcare profession as well. For me, the easiest step and the first step is trying to collaborate. Without taking that first step, the intention of wanting to collaborate, we will never be able to collaborate. And again, it's challenging, but it's not impossible. And with strength, I always say, in strength and unity, we can achieve much more. And we're talking about patients' lives and the quality of life that we all are looking for. We're not merely looking to live longer, but we are looking to live better. So
wow.
It is worth the investment.
Wow, what a very beautiful saying. And let's say this was a rather short interview that we had, but I think that you have really made us very clear that it should be patient-centered and that we should look also at the anticipated outcome measures of the patients. Thank you very much, Robert.
You're very welcome. Thank you.
After the patient perspective, we move now from the patient perspective to a more global view. I'm very pleased and honored to introduce Elisabeth Weidepas. She's the director of the International Agency for Research on Cancer from the WHO in Lyon since January 2019, if I'm right, Elisabeth. For many years before, and I think that you really have a very splendid CV, you were Professor Medical and Cancer Epidemiology at the Karolinska Institute in Sweden, but also you have many connections with Norway, with Finland, with Brazil, with every. 3 years before your entrance at the IARC, you were head of the research department of the Cancer Registry in Norway. And last but not least, 2 weeks before your start at the IARC, we were sharing a taxi drive. I don't know if you remember. It was in the very beautiful Piedmont region, And we were discussing a bit the nice wines there, but we also discussed the crucial role of the cancer registries for the future. So in fact, Elisabetta, I cannot say but that you are very well placed. You're the right woman on the right place now at the right time to speak about the urgency of the cancer problem. And especially also what you promised to help us give visibility to the cancer registries and their role. So please, Elisabetta, the floor and the stage is yours in space.
Thank you. Thank you so much for having me today. And it's really a pleasure and an honor to be here. And I will try to share my screen. So let's see if this will work out. There we go. And then I will put it in presenter mode. And I would like my colleagues to confirm that you can see the screen properly. Is that working fine with you? Yes. Okay, great. So thank you very much for giving me the floor. And I will do my best to try to put in evidence the fundamental importance of cancer registration in Europe and worldwide. So, but before I go into details, I would like just to say a few words about IARC and what we do there, because maybe not all colleagues know what the International Agency for Research on Cancer is about. So IARC is focusing on several initiatives to enhance cancer prevention worldwide. And since I arrived in office in 2019, we developed a new medium-term strategy, and it's summarized in this slide. So we have 4 prevention strategies, prevention to research strategies. The first one is to monitor the global cancer burden. The second one is to do research to understand the causes of cancer, and then to evaluate and implement preventive interventions, and then to disseminate broadly the information, including to stakeholders and to policymakers. And here I include the whole series of books we produce, the IARC monographs, the IARC handbooks for cancer prevention, and the IARC Blue Books, which is the main book on pathology worldwide, which is updated all the time. And then we have developed 3 emerging priorities, which is areas that we want to focus in the years to come. These are evolving cancer risk factors and population in transition, implementation research, and economic and societal burden of cancer. So data and cancer data is really the cornerstone of cancer control. Data is absolutely essential to base our actions and to decide which groups should be targeted with different approaches. A population-based cancer registry collects all reportable cancer occurrences from multiple sources in a defined area, and then summarizes this information in a comprehensible way to guide action. So at IARC, we take cancer registration as really one of the most important activities that we can do. And we want to focus now in improving the quality and quantity of data register, for example, for children, for adolescents, but as well as for adults, adding quality to not only quantity but quality to this data. So we have at IARC quite a focus in low and middle income countries where data in cancer registration is lacking mostly. So we have developed an initiative which is called the Global Initiative on Cancer Registration, where we support countries across the globe to collect data, to control the quality, and then to collate it across countries in a comprehensible and comparable way. So the Global Initiative or Cancer Register is abbreviated GICR, and we have then implemented 6 regional hubs across the world to support cancer registries in Latin America, in the Caribbean, in Africa, in Asia, and in Oceania. So we try then, after collating all this data, to disseminate it as widely as we possibly can. And here I show an example of the Global Cancer Observatory, which is an interactive web-based platform comprised of multiple subsites. We have the Cancer Today subsite that updated the Global CAN 2020 estimates, including data from 185 countries for 36 cancer types. And we have, of course, published the summary of this information in the Journal for Clinicians, and it's widely available free online for you to consult. We have also developed the Cancer Tomorrow subsite, which provides tools to predict the future cancer incidence and mortality by 2040, and has been updated to incorporate user-defined trend-based projections for cancer across the globe. Then we have the Cancer Causes subsite that provides estimates on the population attributable fraction for major cancer risk factors, for example, smoking, smoking tobacco, alcohol consumption, overweight, obesity, and so on. The new addition to this website is alcohol consumption, and it was added in 2021. And we did this in collaboration with the WHO offices, in particular the WHO Office of Europe, because alcohol control is one of the major objectives for the European Union and European countries in the next years. We also added in this website the cancer survival, which is continuously updated to incorporate the most recent cancer-specific results from numerous sites. So to establish research priorities, we must really understand in depth and be able to describe the global cancer burden. So let's have a careful look, what is the most recent compiled data that we have. And these are available in the Global Cancer Observatory and in the Global CAN database. And it indicates that in terms of incidence, we will have almost double the incidence or the total number of cancer cases in the next 20 years or so. So in year 2020, we had 19.1 million new cancer cases, and we expected to have 28 million by 2040. These figures are really alarming, and I think it's a clear sign that cancer prevention is a priority worldwide, and we should be really working together with our governments to implement cancer prevention as soon as possible, because we cannot sit passively and wait for these numbers to hit us. So in terms of loss of productivity, it's also a great challenge, and we can see the figures in this slide. So it's 70 billion. It's absolutely enormous in terms of all the impact that cancer has in communities. So the situation in Europe. So let's go from the world now to Europe. In 2020, we had 2.95 million people with a cancer diagnosis in the EU 27 countries, and 1.27 million people died from the disease. And the numbers will increase, and the increase will be done mainly to the aging of the population, but also because of changing in risk factors. So we predict that 3.61 million new cases by 2040, so quite a substantial increase, and 1.67 million deaths from the disease. So this represents about 21% increase unless we really implement effective measures to curb the occurrence of cancer. Just a few words about the COVID pandemic. So the COVID-19 has clearly had a major impact in healthcare across Europe and across the world. And we consider that the effects of COVID-19 will continue to be felt in the years to come in terms of incidence of mortality. So the risk factors have changed. People have smoked more, started drinking more alcohol, being more sedentary, and this will have an impact on the long term in the populations. Also, diagnosis of cancer was slower to be made. That means that populations will have their cancers diagnosed at a later stage with lower chances of survival on the long term. Also, there was a major impact in cancer registration with most cancer registries across the world being somehow affected. So what's the situation in the Netherlands? So we spoke about the world, then about Europe. Let's now have a look in the numbers in the Netherlands. So our estimates, and I hope this coincides with the estimates that the data from the Cancer Registry that you will certainly be discussing further today. 132,000 new cancer cases in 2020. And the main types were colorectal, breast, prostate, and lung cancer. So these numbers are staggering, is a major burden in the Netherlands. But there is a good news of sorts, is that these cancer types are mostly preventable. So breast cancer, colorectal cancer, prostate and lung, we know, we have knowledge about risk factors that cause these cancers, and they are amenable, at least partially, for prevention. Also, they are amenable to screening and early detection, and they are treatable. And if treated early, patients can indeed be cured. In terms of mortality in the Netherlands in 2020, we had 49,000 cases, so almost 50,000 cases, and the main causes was lung cancer. Again, for lung cancer, we know it's smoking. The vast majority is smoking related, and there is one way to curb this is to make people stop smoking. But also, even if they are detected with a lung cancer, stop smoking at diagnosis also increases the probability of surviving very substantially. So in terms of predictions, so we predict 171 new cancer cases by 2040, and there will be circa 71,000 deaths from the disease. And this represents a 31% increase in the overall burden of cancer if we don't implement preventive measures very, very soon to curb these numbers for almost 40 or even more, 40% or even more. So cancer data tell us that the cancer burden globally and in Europe and in Netherlands is increasing, and there is a massive societal burden. So cancer registration data guides us to act and to act fast. And what our research indicates is that the major causes of cancer in Netherlands, in Europe, and worldwide are tobacco smoking, alcohol consumption, overweight and obesity, and infections, for example, with HPV, human papilloma virus, which is amenable for vaccination to be prevented. And these are really the population attributable fractions that I'm showing in this slide, indicating the percentage of all the total burden of cancers that could be prevented if we would tackle these risk factors in a more effective way. We did these estimates based from France, but they are replicable for Europe and basically the same with very small variations. So there's a great potential for prevention, and so our destiny in a way is in our hands to do something with this knowledge and implement control on the ground. And cancer registration is absolutely fundamental also to control and to measure and to show progress in curbing the cancer epidemic. So the European Union is also has quite a momentum at this moment regarding cancer. So the EU missions have been a task force of the European Union Horizon Europe Research and Innovation Programs for the years 2021 to 2027. And one of the missions was a mission on cancer. Actually, it was the only health-related mission that we were asked to develop. And the idea is really to develop very concrete solutions to propose to the European Commission to target their efforts in the years to come. And what the Cancer Registries community proposed to the missions and that was adopted is that by 2030, more than 3 million lives could be saved by living together and better if we would act together as a community to curb cancer. So, and the priorities, the pillars of priorities were more prevention, better treatment, more lives saved, and better quality of life for patients and their families when living with cancer. In February 2021, the European Commission also published the European Beating Cancer Plan, which sets Europe's approach to prevention, treatment, and cancer care. So the European Beating Cancer Plan and the European Cancer Mission complement each other. The European Beating Cancer Plan is sort of the political platform and set the goals for governments, while the mission has a very strong research component, but also implementation on the ground. So altogether, a great momentum in Europe, a lot of attention being paid to cancer, and this opens the door for the cancer registration community to thrive, to show their value in creating and making clear the importance of cancer registration worldwide, and in particularly in Europe, for action and for measuring the impact of our action. So, in short, I think we can really not tackle the cancer problem just by treating patients. We need to first understand the geography. Where are the cancer cases? Which cancer types there are? What do we expect in the future? And can we prevent them? And if so, how? And for the cancer types that we don't know how to prevent, we really need to speed up the research to understand better why these cancers develop and what we can do about it. And cancer data are the absolutely cornerstone of cancer control. Data is to be used for action. The value of the data is to guide action. And this is really one of the fundamental pillars of our activity at IARC, but for each and every cancer registry in the Netherlands, in Europe, and globally. So high quality cancer registration should definitely be the basis for implementing evidence-based cancer control programs. And the global initiative for cancer registration will continue to assist low and middle income countries to develop capacity for registration all over the world. And I really count on the cancer research community and the cancer registration community in Europe and in the Netherlands to support this initiative, to disseminate knowledge and to support the registers elsewhere. So I think I will stop here and give the floor back to you and to see if there are questions, comments, or if you would to clarify anything. Thank you very much.
Thank you very much, Elisabetta. And indeed, we have some questions that entered the chat. And one of the first is, what is the role you see for cancer registries in prevention? Because you dig into the different aspects of alcohol consumption and tobacco smoking, but what can the cancer registries do in their work?
Thank you. Thank you for these questions. The cancer registries can do a lot, and they can really first set the ground, indicate it to the governments what's the incidence, what's the mortality, what's the survival in their region or in their country, depending if the cancer registration is just for a region or for the countries. And then show the importance of cancer in that region or in that country. Then another initiative, together with researchers, is to calculate the population attributable fraction for different risk factors in the country, and then argue or provide this data for the governments to guide cancer prevention initiatives. And based on the registry, you can also guide or monitor progress in the fight against cancer. If you have a certain incidence and mortality at 1 year, what in your cancer plan for your country, what do you want to have in 5 years, and which are the measures you are going to take to decrease incidence and mortality? Also, a very important thing is the data on survival. By monitoring survival, you can benchmark countries and regions against each other to understand where do you need to work harder to make progress, to improve quality of early diagnosis and early treatment. So you can monitor all this based on cancer registry data. So there are many ways of using cancer registration. And I think it's absolutely needed to have a cancer registration in a region and in a country, because without that, the Ministry of Health is basically flying blind. They don't know where they are going and which should be the priorities for their action.
I think that your answer is immediately also tackling maybe a bit of the next question, because how can cancer registries that already provide these data gain in visibility? How can they work on it? What should they do? How can they become visible?
Yes, I think that's a challenge, because there is somehow an overflow of information, social media and other means, And I think what we have also observed with the COVID pandemic is that science is not always easy to communicate and to transfer knowledge to the public in a way that they would understand it. So, for example, if you see the entire vaccine resistance to COVID vaccination, and you think, well, this is just illogical. I mean, we are providing all the data showing the efficacy of the vaccine, but there is still a percentage of the population that refuses vaccination. I think similarly with the cancer registration information, we can show the numbers, how many cancers we have, how many cancers we can prevent, what's the impact, for example, of screening, and how better the survival is amongst the population screened, in particular if you can link the information from screening programs to your cancer registry. But the way we communicate that needs to be improved, dramatically improved, I would say. And I think we really need to associate ourselves with other professionals which are specialized in health communication or public health communication, or simply in communication per se, because epidemiologists or cancer registry staff is not necessarily specialized in how to communicate science, and is a major challenge. And I think there's a lot to be learned by joining forces with professionals of communication in that regard.
Thank you. Communication is indeed one of our challenges, and I think that is really a challenge for every cancer register. And what about cancer registries can really very differ in quality and quantity that they are presenting, and how should we even go further in collecting data, for example, more on stage and treatment, because we have that balance between the differences of the cancer registries? Should we improve quantity and be complete? Should we go on with the cancer registries that are well equipped to move on with stage and treatment, for example? What is your opinion about it?
Yes, in short, yes. I think stage at diagnosis, it's absolutely fundamental. And also patient-reported outcomes. I think cancer registries, as in the Netherlands, that if you have the possibility to include for some key cancer types, patient-related outcomes, this is very important because it will guide you in the amelioration or improving the system. So not only, I mean, the traditional information that we collect in cancer registries is absolutely fundamental, but I think stage is very important to be able to understand survival and to identify holes in the system where you need to improve, but also patient-related outcomes. Another very important thing is to incorporate other databases in the register or make them linkable. Linkages between different databases, for example, screening databases and vaccination databases, because this will again guide you to how to change public health practice for the benefit of the patients and the population in general.
Yeah. You give us a lot of challenges, and I think I couldn't help seeing when you were presenting for the NCR that you had a card on it on focus, and I think that you have given us really many focuses to work on in the cancer registries, and that many challenges are standing now. So thank you very much, Elisabeth, for your time, for your way of answering the questions and tackling the questions, and your very good presentation. Thank you so much.
My pleasure. Thank you.
Bye.
Bye.
The challenges for European cancer registries were indeed already clearly highlighted by Professor Weiderpass. And this is then the right moment to jump to Dr. Magdalena Stepien, who worked for years at the IARC also of the WHO in cancer epidemiology research, but she is now at the Joint Research Center of the European Commission, where she helps to set up the new and very recent European Cancer Knowledge Center. So let's listen together to Magdalena and then come back to you again.
Good evening, everybody. The EU Knowledge Center on Cancer, KCC, it is a virtual center that is led by JRC. It was launched end of June this year. It is a part of the Knowledge for Policy platform that we also host here at the JRC. that aims to bridge the science and policy gap. To explain maybe more about the Knowledge Center, it is built on our 4 scientific competences, which is cancer prevention, cancer information, cancer guidelines and quality assurance schemes, and rare disease registration. So what we do is we basically provide IT systems, gateways, portals, databases, platforms to support policies for cancer prevention, early detection, and improved care. To give you some example on our collaboration with the Cancer Plan, we will take part in the update of European Code Against Cancer. We will also support the new EU cancer screening scheme with our guidelines and quality assurance schemes. So I would say overall, the unique role and the vision of the Knowledge Center on Cancer is to foster coordination and alignment between all of these activities and initiatives, mainly to avoid duplication in the efforts in the EU fight against cancer. There are some bottlenecks definitely in the fight against cancer that we can help to support. And first of all, still striking inequalities are observed in cancer care among European regions and countries. So our technical support with the cancer guidelines aim to address these inequalities. We are also contributing to the setup of the Cancer Inequalities Registry. That is a tool to monitor and report on, as well as highlight the potential disparities in addressing cancer prevention and care across Europe. Another possible bottleneck is prevention. We know a lot about the risk factors for cancer, but now it's time to implement effective policies that will improve people's health, but also to evaluate the effectiveness of these policies. And for this, we need a timely provided data on cancer and incidence. So here come our competences on the provision of cancer statistics through the European Cancer Information System, and information we provide on effective policies through our health promotion and disease prevention knowledge gateway. A gateway that compiles evidence-based information, including health-related policies on cancer risk factors, associated conditions, and now expanding also to include information on different cancers. The National Cancer Registries and the Knowledge Center have been already working together for several years. The JRC, now under the umbrella of the Knowledge Center, hosts the Secretariat and provides support to the European Network of Cancer Registries, which is a network of over 150 population-based cancer registries in Europe, including the Dutch Cancer Registry. The contribution of the cancer registries, I would say the most importantly, they are the producers and providers of the data that is used to compute our European Cancer Information System estimates for the efficient monitoring of the cancer trends in Europe. Our role as the data broker in this regards is that while using this data, we give the visibility to this work done by cancer registries, but also link it to policymakers. The challenges now we are facing is to enrich the EKIS data with some additional information, for example, clinical information, to geoposition the data and link it to demographic, environmental, and other related data sets that could in the future support more targeted cancer prevention. So what are possible rooms for improvements? First of all, I would say the harmonization and comparability of the data, as well as the increasing completeness of the data that is collected, addressing the timelines of the information collected, as well as the population coverage. Cancer registries are the official source for monitoring of cancer burden in a population, so their data should also play a major role in evaluating the effectiveness of preventive interventions against cancer, but also on monitoring of the progress of national cancer control plans. So I would say that cancer registries are not only providers of the data, but very important stakeholders that maybe could also engage in communication of the knowledge we have. For example, by disseminating the European Code Against Cancer, which is a set of 12 actions that we, citizens, can take to decrease our cancer risk.
Thank you very much, Magdalena, for the overview on the new European Cancer Knowledge Center. You really place the cancer registries centrally, and that is really what we like as representatives of cancer registries. And you indeed mentioned one of the roles being, and considered also as the core business for cancer registries, to be a data provider. But it is already clear for years that the Netherlands Cancer Registry really goes far beyond that. And a person that really embodies this completely for me, and I'm sure many of you together with me, is your Valerie Lemmens, member of the Board of Directors of the IKNL, Head of Department of Research and Development, and Professor of Cancer Surveillance. It is such a pleasure, Valerie, to introduce you, thinking back to the early 2000s, sitting together in the small and, let's say, documented bureau of Jan Willem Koeberg, your and also our mentor, discussing the ongoing projects on quality of care that were already far in the Netherlands and the need for the startup in Belgium. Such a pity that we couldn't convince you to come to Belgium, but okay, we can live with it. If you allow me, I would first like to start with a question for you before you tackle your presentation. What would you now expect in return from that new center, that Knowledge Center of Cancer? Please tell us.
Well, thank you very much, Lisbeth. First of all, thank you for your very kind words. And it's an honor for us to have you here sharing our evening symposium. And about your question, please allow me to rephrase your question and maybe not ask ourselves what we can do for the Knowledge Center, but what can we do for each other? I think, as it was expressed by Elisabetta already in a wonderful way, it's all about cooperation in Europe. It's all about coordination of the many, many activities which are going on already. But I think it's a nice question that we can address later on during the panel discussion, if that's okay for you, Lisbeth. Well, let's go back to the Netherlands. Let's focus on our country in a European perspective. And let's see what is coming to us as an organization, but much more important, what is facing our society in the next decades. And I think Elisabetta already showed you some worrisome numbers, but let me give you some more detail about these numbers. Well, if you want to say something about the future, it's important to have a look at the present situation. And if you look at the current slide, which is shown here, you see the population pyramid in the Netherlands as it is right now. And all of you, of course, have heard about the baby boom, the post-Second World War baby boom. And many people think, oh, it's the generation of people born right after the Second World War, so those people who are now 75 or 76 years old. And that's the generation which you can see in these small vertical peaks at the age of 75. But when you take a step backwards, you can see that the baby boom actually goes on until people born until 1975. That's including myself. And this is depicted by the, let's say, pregnant belly of the population pyramid. People who are aged 47, 48 right now are also part of this enormous baby boom. Now, imagine, turn the clock forward 10 or 15 years. You can imagine what will happen with this pregnant belly of this population pyramid. And then bear in mind that thanks to the Netherlands Cancer Registry, we know that in Holland, the average age at which people are diagnosed with cancer is 69 years old. So what does that mean to future cancer incidence? Well, this. You can see an enormous increase in the number of cancer patients in the next decade. To be short, in words, and I'm afraid that Elisabetta was already a little bit too optimistic in her projection about the number of cancer patients in the Netherlands in the future, because from the 120,000 patients, new patients per year right now, we grow to a staggering 170,000 new cancer diagnoses in 10 years from now. So this means a huge burden on society, a huge burden on our healthcare system. And not only we will have more people diagnosed with cancer, we will also have more older people diagnosed with cancer, as you can see here on this slide. From 2030 onwards, the majority of patients is age 75 or older at time of diagnosis. Now, this puts an extra effort on the healthcare system because treatment, also diagnostics, also follow-up of older patients is often more complex, for example, due to comorbidity. Now, you might think, okay, a Western society here in the Netherlands, we have a lot of old people, so, you know, it's normal that we will see this increase. We have a good healthcare system, and maybe we are a relatively healthy country. Well, dream on. We are not. This was also already shown earlier today. If you look, for example, at the cancer incidence, total cancer, in the Netherlands, and you compare it with other European countries and the European Union average, as you can see here in the middle of the slide, the situation for females, we rank third. We rank third of countries with the highest cancer incidence in females. For males, we don't do much better. And now you might think, okay, we have a lot of cancer diagnosis, but we have a good healthcare system. We can treat these patients very good. So what's the problem? Well, if you look at this graph, also if you look at cancer mortality, it was also shown before already, we don't do better than the European average, even more so. We do quite much worse than the European average. So we still have work to do. I also want to give you this interesting slide where we put the Dutch situation in the European perspective. And in this slide, you can see which cancer types are more common in the Netherlands compared to the European Union average and other European countries. And it's fascinating to see that, for example, if you look at only the first two cancer types, which are much more common than in the European Union on average, it's melanoma and it's esophageal carcinoma. Both are related to lifestyle factors. As Elisabetta already said, these cancers are potentially preventable. They are related to exposure to UV light. They are related to obesity. Now, I will not only tell you bad or sad news this evening, I can also tell you some good news. And maybe in this time of COVID pandemics and measures against it, it's good to also sometimes focus on the good news that we have to tell. Because thanks to the Cancer Registry since '89, we can see what is the development of cancer survival. And at this slide, you see a picture of the enormous improvement in cancer survival in males. In females, it's more or less the same improvement. If you look at, for example, 5-year survival, it has improved in 30 years' time from about 45% to 70%. Still a lot of work to do, but I think also IKNL, also the Cancer Registry has contributed to this improvement. Thanks to the Cancer Registry, we are able to monitor these improvements, and we also can identify areas where we have to improve more. Now, here I show you the improved survival. I just showed you the increased incidence rates. 1 + 1 is 2, because if you look at the prevalence, which is defined as the number of patients alive who ever have had a cancer diagnosis during any time of their life, we can see an enormous increase in the forthcoming decade. In words, we see the number of people alive who ever had a cancer diagnosis in the Netherlands increasing from 850,000 now to a staggering 1.4 million in only 10 years' time. Now, also this will put a huge effort on cancer control issues in the Netherlands, but also cancer survivorship care will be more essential than ever. Now, I also want to show you some cancer-specific results. It was already shown today. Lung cancer rates, especially in females, they keep to rise. They keep rising because females in the Netherlands tend to keep smoking. And if you compare, for example, mortality rates for lung cancer for males and females, we see that in 2032, in 10 years' time from now, females will have an equal mortality of lung cancer, which was a long time regarded as a male disease. They will have catched up, unfortunately. Melanoma, I already told you that melanoma in the Netherlands is far more common than in most other European countries. If you look at the increase in melanoma incidence between 1990 and 2030, it's a 500% increase. It's a 5-fold increase. Why? Of course, also because people are aging in the Netherlands, but especially the increased exposure to UV light is responsible for this increase. Another example, I could have showed you many examples, but all of this will be part of the report Trends in Cancer in the Netherlands 2030, which will be brought out in 2022. But here I just want to show one example of a quite rare cancer type, which is related to both aging and obesity, and the enormous effect this combined risk factors have on the incidence. It's a 700% increase in only 30 years' time. One last example, esophageal adenocarcinoma, also related to aging, but also obesity, especially in males. Also here, this tumor type, luckily, is improving in survival, but still, the increase that we see in incidence will mean that many, many more people will die of esophageal adenocarcinoma in the next decade. Well, I showed you a large increase in cancer incidence rates due to demographics, with an increased proportion of elderly patients, which will lead to an enormous increase in the burden of care. And we also have to think that in the near future, we will have a decreased working age population who will have to take care of an increasing group of elderly patients with cancer. And on top of these demographics, the rates also increased due to exposure to risk factors, smoking, obesity, UV exposure. And as Elisabeth already said, we have to make a clear plea for stronger prevention policies. And the cancer registries in Europe, also the Netherlands Cancer Registry, has an important role to do here. And now I just want to give you briefly one example of the role that we are taking up in cancer prevention. As Elisabeth already told you, it's also important to identify where do these cancer patients live. And if you look at this example of the Cancer Atlas, which will go live in 2022, you can see the example of mesothelioma, related to asbestos, of course, as you probably all know. And in this map, you can see very clearly in red the increased incidence in areas surrounding industries of asbestos producing and asbestos processing factories. And unfortunately, this is the situation today. This is not a map from the 1980s, for example. No, these are people dying of mesothelioma right now. And if we would have had this map in the 1980s, if we would have been able to show these types of data earlier, we would have been able to save a lot of lives. So we have the responsibility to look at a specific region to see, to identify if there is an increased risk of developing the cancer and to find out why we see this increased risk. And of course, the people in the Netherlands probably recognize this picture. It was in the news, on television, in a lot of media. This is the discussion about theta steel and lung cancer. I don't want to go into detail here, but what I want to say is that it's sometimes good to take a step back and to look at the broader picture, to put things into perspective. And the atlas will make this possible. For example, here, if you zoom out, you don't see only high lung cancer rates near Tata Steel, but you also see high cancer rates, for example, in a number of areas in our capital, in Amsterdam. And to put things even more into perspective, I put another picture here next to it. It's a smoking prevalence with the dark green spots, meaning that people have been smoking there more. I don't want to say that Tata Steel does not have an influence on the health, on lung cancer in the area surrounding Tata Steel, but I think with the linkage of the atlas and information about risk factors, we can always put things into a better and broader perspective. So to wrap up again, besides the incidence increase, we saw a strongly increased prevalence due to increased incidence and survival. And we cannot stress enough the importance of cancer survivorship care, and that we have to be ready for the increased burden also of follow-up care in not only hospitals, but also primary care. And the cancer trends shown will have a large impact on all of us as a society, on you, on me, on our organization. And it's time for all stakeholders to act now to prepare for the cancer burden which is coming towards us. And one of the ways that we can coordinate and make plans for the long future is the so-called Dutch Cancer Plan, or the Nationale Kankeragenda. And Mr. Johann Van Der Gronder from Dutch Cancer Society will talk about that later this evening. For now, I want to thank a lot of people who have been doing the hard work, especially Jijke Praagman and also colleagues from the R&D department, and of course all data managers. Without them, this work would not have been possible. So thank you very much for listening to me, and hope to see you later this evening at the panel discussion here. Thank you.
Thank you, Valerie. I think that you have a crystal ball to predict, but also very good statisticians to work together with you to implement this. And thank you for joining us here now at the table for questions. And I would like to launch a very first question, saying, if you were a politician, what would be your first measures that you would like to implement now if we see your data?
I would like to go back to my last slide. The Nationale Kankeragenda, I think this is the first step. Of course, we have a lot of very good initiatives in the Netherlands when we are talking about quality of care, access to health care. A lot of things are being done, but we don't see, as we see in some other countries as well, enough cooperation between these different initiatives. I think it's time that also in the Netherlands we come up with a plan for the longer future, that we don't think only about now, about the next year, but we think 10 years ahead. And this takes, of course, courage, especially from politicians. So if you ask me what is the first step to take, then I would say, let's start a coordinated action today.
Yeah, and I think we will need to listen also to the next speaker to hear about that, because you are suggesting concrete action. We have a couple of questions that are entered into the chat box. And there is a question about what is the quality of the other cancer registries? Can you compare data? Should you be very careful with that? Are numbers comparable if we look at quality?
Yes. Well, it depends on what measure, what outcome measure you look at. With respect to mortality, I think these data are absolutely comparable. If you look at incidence, of course, we know that in some countries, the completeness might be a little bit less than we see in the Netherlands. I think it's a bigger problem if we compare survival. If we look at survival rates, the Netherlands don't fare very well. We don't do better if you look at survival rates than, for example, the European Union. I think it is more due to registration artifacts. But if you look at incidence or mortality, I think the pictures that I have shown are true pictures. I don't think if other countries would have had a perfect cancer registry, that the picture would have looked different. Unfortunately not.
Oh, so that means a lot of work for a lot of cancer registries in order to improve comparability, like Elisabeth told us also. There was also a remark about, in France, for example, we only have a limited number of cancer registries, and they extrapolate, of course, to have data on France. So I think that we can say that you are really exemplary here in your work. I could launch maybe a very short question, but thanking you for your interesting presentation. And is the increased incidence of cancer in the Netherlands compared to other countries in Europe solely due to a higher exposure to risk factors?
No, it's also about demographics. I think the data that I've shown are clear about that. If you look at the increase in absolute numbers, the biggest explanation for the increase that we see in the next decade is aging of the population, no doubt. But on top of that, we see for some types of cancer a larger increase because of, for example, exposure to UV light. The example of melanoma that I've shown. Obesity rates have been increasing in the Netherlands. I gave you the example of esophageal carcinoma, and I can give many more examples of that.
And you have screening.
And we have screening, of course. So there are a number of explanations why we see this large increase in the Netherlands. Elisabeth showed also that in all of Europe, in the whole world, we will see a large increase in the number of cancer patients. So it's an international problem. But here in Holland, as I showed you, we, for example, have much more patients with melanoma, much more patients with esophageal adenocarcinoma. So it's good to be able to look at the different countries and to make sure that prevention policies start to work there where they are needed.
And then we should maybe conclude to say that politicians should not look at the next 5 years, but as you were presenting for 2030 and even 2040 by Elisabeth, that we have to focus on future again and to plan our healthcare. You
Absolutely,
agree?
absolutely.
Thank you very much, Valerie,
you.
for this nice chat. Let's have a look at the next small film, the 10 Flagships, European Beating Cancer Plan. And I hope it will open up emotions, even though it's very short, but have a look and let the emotion go now.
we can make a difference with prevention and with research, with equal access across Europe, standing at the side of those who need us. This is the vision of Europe's Beating Cancer Plan.
We can strip away the fear and the uncertainty that comes with a cancer diagnosis and replace it with determination, with dignity, and with hope.
We welcome our next speaker, Mr. Johann Van Der Gronder. Since 2018, he is the Chief Executive Officer of the Dutch Cancer Society. Graduated in the humanities, philosophy, and with, I know, a very broad interest package, professional experience and vision, not only in human nature. You were right, Johann, we did not meet yet in person, but exactly 2 years ago, during the symposium of the 30 years of cancer registration in the Netherlands, you gave an inspiring lecture, Living with and After Cancer. But I was hidden in the public. I was already preparing this meeting. We had a global view on cancer control. Europe has a Beating Cancer Plan, and I think that you have an important partnership and vision to introduce for the Dutch cancer agenda. So please, may I offer the floor to you for your presentation. Thank you, Johann.
Ladies and gentlemen, good afternoon. It's an enormous pleasure and honor to be with you here tonight. First, a confession to make. At my dinner table, my daughters call me a boomer. You know, I don't know if I am a boomer. Actually, I would be a very late boomer, but they somehow enjoy the expression, and then I have to explain my behavior. Well, I think my dear colleague Valerie has referred to this boomer generation because actually it will play quite a big role in my presentation tonight, so I feel very much involved in the very topic I want to share with you. Now, when I drove up here to this studio to address you tonight, I was just thinking, when do I assume that my talk is a success? Well, let me mention to you a few very simple things. If you go home tonight or log out of the live stream and you think that this talk was, one, urgent, second, a no-brainer, and third, something to get your hands on tomorrow, it'll be a success. So the next 15 minutes or so, I would like to take you on a journey for a Dutch cancer plan. These cancer plans are also known as cancer control plans. It's already been quite a while that the WHO passed a resolution actually recommending countries to, if they want to make an impact on cancer control in their countries, to start writing a cancer control plan, a comprehensive one. We did so in the past, but unfortunately our current one is expired, has expired quite some time ago, and we are without a comprehensive cancer plan currently in the Netherlands. I am ashamed to say so, and I'll make the case that we need to build one. You have already learned from Valerie, and actually I'm very grateful to the previous speakers, both Elisabethe and Valerie, to light the burning platform here tonight, because obviously you have been, or will have been, if not shocked, at least surprised by the incidents and the tsunami that's coming our way. So 1 in 3 people in the Netherlands will be confronted with a diagnosis, and they haven't told us man, it probably will be 1 in 2. And these cases now stand at 150,000 a year. They will rise to 165,000 by 2030. And almost 50% of these cases are people younger than 69 years. So we have already 800,000 people living with or after cancer today in the Netherlands, and we will pass the 1 million bracket by 2030. And this is an optimistic figure. I've also seen calculations of epidemiologists who say this might actually be closer to a figure of 1.4 million on a population of 17 million. This is a major burden and a silent pandemic that's taking place. So 45,000 new diagnoses per day currently, and as I told you, relatively young people being affected. So you understand that many of you are actually working in this field. The demand for care in these welfare services is increasing, and it's already significant. We're currently in another pandemic, and we know that the critical cancer care is at risk as we speak, even in such a high developed, very, very rich country like the Netherlands. And as the number of cases is rising, at best the number of employees in the healthcare system will remain the same. So it will put a lot of pressure, and the healthcare cost, as in many European countries, are rising faster than the growth of our GDP. So we need to do something here. It's quite simple. Joining forces in an integrated approach is necessary to tackle those complex challenges. Elizabeth referred to human nature at the beginning of this talk. Well, humans tend to get together, but to have them cooperate is a different ballgame. It needs a little bit of nudging and a little bit of coordination. Now, those of you who are not familiar with the Dutch language might think, my goodness, what is this? I am confused. And I can tell you that if you're a native Dutch speaker, you also think this is spaghetti. But this is actually the field of people, organizations, foundations, charities working in the field of cancer control as we speak. So there are a number of national initiatives. There is a national initiative to combat skin cancer. There is a national survivor task force initiative. There are many plan makers. There's obviously a ministry out there, if not more departments involved. There are research agendas. There is an EU beating cancer plan. There's an EU horizon on the context. But how does it all come together? It doesn't come naturally. It needs focus. It needs coordination. So the way we plan to do this is actually quite simple. All good plans are quite simple. We look at the patient journey and have actually 4 angles here. So it's prevention and early detection, diagnosis, treatment, and follow-up, living with and after cancer, so the quality of life, and then slightly different from the EU Beating Cancer Plan, and I think Elizabeth has referred to it in a previous talk 2 years ago, also palliative care. The Dutch Cancer Society has for quite a while, if not neglected, has spent insufficient attention towards the very important topic of palliative care, and we think that this needs to be included in a comprehensive cancer plan. So you can zoom in. You can take, for example, the EU Beating Cancer Plan and then map this on this approach and see where it overlaps, where you find a gap, the palliative care, and where, for example, on prevention and early detection, you see a lot of overlap. And then this needs to be coordinated. And there are sort of 4 pillars underneath: on research, on organization and quality of care, on data, as we are with the National Cancer Registry here tonight, obviously, and it needs to be funded. I can say with some pride that the Dutch Cancer Society has actually grown to become one of the primary sources and main sources of private funding of cancer research, both base research and applied research, clinical research in the Netherlands over the past decades. We've been around for 70 years. But I should also add that we do not exactly know how the surroundings look like. So it's great to be a great player, but it's even much better if you have a good understanding of the alternative sources of funding and on the complementarity of the whole scene, including the sources that might be available at the EU level. So we want to have a plan, and again, the slide itself is Dutch, but you don't have to look at that at the moment. It's just that we want clear, smart, measurable, and ambitious goals on the 4 to 5 pillars I have just mentioned. And we've actually set the scene. We have identified all the potential, both the low-hanging fruit and the middle to long-term objectives. And I'll get back to the main objectives later on in my brief talk. So what would be the added value of a coordinated effort of such a cancer control plan? Obviously, to reduce the impact of cancer by joining efforts in an integrated long-term approach, by describing a clear means of achieving your goals, by making them measurable, obviously also to limit the cancer burden by trying to be much more effective in the prevention. We need to prevent more cases because otherwise we will be swamped with cases in terms of care and cure, and we need to accelerate early detection, diagnosis, and better treatment. I say this within a context that within the framework of our own ministry, there is a tendency to frame cancer as a chronic disease. And I take great exception at that. Cancer is not a chronic disease. It is not even close to a chronic disease. If 45,000 citizens are dying every year, if the 5-year survival rate stands at 65%, we cannot yet be talking of a chronic disease. We still need to treat cancer in a curative fashion, and we need to get to deal with it urgently to prevent, to better treat. And as you've seen, Valerie has also pinched a little bit the dreams of yours who still thought that the Dutchies were at the top of the pyramid when it comes to effective care or even incidence, and at best we are somewhere in the middle range. And we don't like to be in the middle range. We should be wanting to be on top of that very pyramid. So the starting points you have been able to read on this slide, I won't dwell on it for too long. Our ambition is to be ready and get it signed in 2022. That's next year. We have been a little bit hampered by the curious case of Dutch democracy with a caretaker cabinet that's been taking care for almost a year now. We are desperate for a cabinet that's actually in full charge, for a minister of healthcare who has the mandate of our parliament and of the citizenry of the Netherlands to actually tackle this very problem. And we know, and that's a very good encouragement, that almost the 150 parliamentarians in our system have voted in favor of drafting such a cancer control plan or agenda together with the Dutch Cancer Society. Unfortunately, the caretaker cabinet or the caretaker minister for health has deferred it to his or her successor, and we hope that he or she will actually take on his or her seat by Christmas. Because I'm a little ashamed to say that the initiative for such a plan comes from a charity, the Dutch Cancer Society, from the Patient Federation, and from the Cancer Registry, our host tonight. This is also a bit of an exception to a rule in Europe, because in many countries it's actually the government taking that initiative, and we have to work hard to get the government on board. So the overall target would be that the plan contributes to a significant reduction of the impact of cancer of patients and society in 2030, with fewer people with cancer due to healthy lifestyles and the living environment. You've heard from Valerie earlier tonight that quite a number of our incidence cases are related to an unhealthy lifestyle, maybe too sunny and too affluent in the Netherlands, and we can deal with that. We want to increase the 5-year survival from 65 to 75%, obviously with a good quality of life. My friends from Cancer Research UK have a wonderful sort of marketing phrase which may be easier to remember. 3 out of 4 in 2034. I love that phrase, but I'd like to have 3 out of 4 in 2030, even if it doesn't rhyme. And then an optimal quality of life for patients and their relatives. Because as you imagine, also in the informal healthcare system, the recruitment and the training of volunteers, we need to see system change, not incremental change, but system change to deal with the tsunami that's coming our way. So, the time is, I hope, now and not tomorrow. We want to work together towards a resilient health system, and we know, and many of you know, and we actually experience it from day to day, the way that we have organized our health system currently cannot deal with the type of health hazards that are part and parcel of the 21st century. We need to rethink our health system. We need to rethink how we deal with pandemics, and we need to rethink to what extent so that the low cost, the bottom line, the efficiency phrases actually are still applicable to a good healthcare system. With the number of intensive care beds currently in the Netherlands among the lowest per capita in the European Union, and I'm not proud of it, and we should change it. As a matter of fact, I think I am almost at the end of my talk. Just one word on the project approach. We propose a very simple organization with an independent chairperson, a small project office, and then a number of working areas underneath. We are negotiating with an independent chair currently and hope to have him or her appointed very quickly. And I'd like to remind you of similar cases like how do you deal with a climate crisis? Well, actually by organizing a national plan, by inviting all stakeholders to the table and to make sure that you come with a plan that actually allows for synergy to happen. That's exactly what we need to do in the case of cancer care and prevention. So the next steps I have here, we're more or less at the early end of this arrow, but we hope that we can speed this up very early in 2022 because we have no time to lose, and we hope that all of you will help and participate. Finally, and then the floor is yours for another 5 minutes for any questions you might have. Obviously, we would need a good dashboard so that we can actually monitor progress against measurable targets over time, on target, on budget. Thank you very much.
Thank you very much, Johann. In a nutshell, but what a kind of project you will be tackling with 3 parties. And thank you for joining here at the table. And the question that is really burning, I think, for me, but also for others that are questioning you, how could be the role of the government in this? Because it has been asked so many times that I have to ask you this question. How would you like to see the role here of the government if you have one? This is really not a joke. This is really, how would you like to see that?
Okay, I will try not to be party political, but I may have to say a few politically incorrect things. So I think we're waking up from and the choice is yours, either a neoliberal dream or a nightmare, where thou shalt not have plans. Thou shalt not make plans. Thou shalt not take coordinated control from central government, because it's society and the stakeholders who have to come together, and then the government will play a process role. I think we have learned the hard way in the Netherlands that this does not work. So we need a government with a vision. We have a prime minister who has been on record to say, if you have a vision, you need to visit an ophthalmologist, right? That's what he said. It may be a great joke, but for God's sake, let's get over it. Make a good plan. I need the government, we need the government, full-fledged on board. And it doesn't have to be top-down, from state downwards to sort of lower levels of governance. Well, we need them there in a very engaged fashion.
And not on a short term, on a middle
want them there
and
tomorrow.
on a more long term, because how can you tackle the many problems? How will you choose in these many problems your urgencies and your priorities? How will you do that then?
Well, I think the government has a very sort of first primary instinct to help sort of control the cost of a rising healthcare system. And unfortunately, cancer care and treatment, and definitely a number of, well, quite, you might say, expensive or at least costly treatments in the pipeline, will urge them to the table. We have to tackle this in a coordinated fashion with all stakeholders, because otherwise we're running into great trouble.
Mm-hmm. And that's maybe what somebody is saying too. What is your message then to our national leaders, or also maybe for us? If we see cancer cases rising the next 10 years, less employees also in healthcare, and that related to also to the COVID parameters.
It means that we need the brightest brains and the best logistical people and all the stakeholders at the table. We have excellent people all over that map I've shown. I've sort of jokingly called spaghetti. But there are excellent institutes,
convince you to
hospitals, excellent academic hospitals. There's brilliant research in the Netherlands. There are good startups. It's a good sort of business environment. But you need a coordinated plan with all of them to make sure we get from this sort of average, medium performance to the top of the range. And that generally tends to speak to Dutchies. We want to win the World Championship next year in Qatar. Even if we would have wanted it to be at a different place, we want to beat the Belgians too. We want to win, the most medals at the Olympic Games. I want to win the cancer control area here in the Netherlands.
And let's get back to the persons that we need to involve. So how can you stimulate a healthier life in combination with all the economic and the political forces that are now ongoing? For example, also smoking.
Well, there's one thing that the government needs to do now, and actually to raise taxes on these cigarettes and tobacco products, right? This is a decision that threatens to be deferred, also because, again, we're a caretaker, don't want to take that decision. We need to take those decisions because there are people's lives involved.
And the persons that we need to motivate. We need to motivate them. So there is an insight of that we have to change some lifestyles.
Of course we need to change lifestyles.
How can we do?
But it's very hard. But we have excellent also behavioral scientists who can help us. We need to campaign, we need to reach out, you need to define target groups, but it means it doesn't happen on itself. No. It doesn't happen spontaneously. We Dutchies, for example, still tend to behave in the sun as if we're Northerners. We need to behave like we're in the Mediterranean. Wear a hat, protect yourself, don't sit in the sun between 12 and 3 in the afternoon on a sunny day. This is strange. Huh? So look at the cancer atlas of Valerie. Yes. You will see that the cancer incidence exactly on the coastal areas where people like to sunbathe is much higher than the other areas of the country. We need to know these things and then provide alternatives. You can lead a very happy and healthy life without burning yourself in the sunshine and look healthy too.
And you have the perfect weapons now. You have the patients, you have the charity and your organization also. And you have the cancer registration and the IKNL, so it should be a success. And
if I'd be in government, I would say this is just a gift. You have all the societal energy and organization. Join us.
Join us. Wonderful message. Thank you so much, Johann. Thank you for this chat. When we are looking at good and powerful cancer registries, and cancer registries also taking the lead, then we easily arrive at Nordic countries. One of the reasons being their long history in cancer registration, but also their way of working together between countries. And we are very happy to welcome Siri Laroningen to this symposium. She has worked in the cancer registry for almost 2 decades, with a focus on cancer coding, registration, classifications, terminology, and data flows, including automatization. And maybe some of you will say, oh, this is maybe some dry theory, but this is not true. These are crucial aspects for a cancer registry. And you are very able, Siri, to make this very speaking and alive. Witness of this, I have to share this with our public, that you were the winner of the European Network Cancer Registries Prize of the most active and interactive person during our Congress mid-November. So, since 2019, you are the head of the NordCan initiative, the Secretariat. And NordCan rings a bell for many of us. So we are really ready to listen to you about the messages you could give us from the cooperation of cancer registries in the 7 Nordic countries. The floor is yours, Siri.
Thank you very much, and thank you very much for giving me the opportunity to say a little bit about Nordcan. And that is, of course, one of the big fruits of the, the Nordic cooperation. And I will run through the first parts of this presentation very much like Daphne Skippers is running 200 meters, 100 meters, very, very fast, and spend a little bit more time on the usability of Nordcan and the lessons learned from this, effort that we are doing. So Nordcan is the fruit of a collaboration for the Nordic countries way back since the 1950s, so it's a long-term cooperation, and also a collaboration with IARC. We made a web tool in 2002, which we have now renewed. We had to change the technology a little bit to make it more visually pleasing and more dynamic. And it provides incidence, prevalence, mortality, and survival in the Nordic countries. These are the 4 cornerstones of the cancer epidemiology. So Nordcan is, in fundament, a tool for cancer surveillance. As I said, this is a cooperation between many parties. It's the Nordic countries, it's ANCR, which is the Association of Nordic Cancer Registries. We have the Nordcan Secretariat hosted in Norway now from 2019. It used to be in Denmark. Denmark has done a tremendous work on this. And we also have the funding from the Nordic Cancer Union, so bringing a lot of cancer foundations together to work on this. So what can you find in Nordcan? Well, there are fact sheets that explains the incidence and trends for most of the cancer sites. You can find different ways of visualizing incidence and mortality statistics. You have predictions to look into the future. You have demographics. Some been shown already today from the Dutch report. You have prevalence, how many people living with the cancer diagnosis today, and you have survival. So we have all of this and very nice visualization for different purposes. It looks like this. I'm not going to go through the statistics here, but you can see it's quite visually pleasing. It's dynamic. On the left side, you can choose, you can click countries on and off. You can do regions of the Nordic countries. You can choose cancer sites, male, females, together or separate. And this is an example of the fact sheets, and we have that in the different languages, the Nordic languages as well, so you can get a fact sheet in your own language. We also have the cancer dictionary, because it is important to know which cancer sites are we really counting in this group and this group. And that is also translated to all of the Nordic languages. All of this data is ready, available for anyone who wants to use it. So you can download it to different file formats using directly from the web tool. So please just use it for all it's worth. We have done quite a big job the past couple of years to look at the data management and flow in Nordcan. Because like all cancer registries, I think, we had this old way of sharing data. We extracted all of the data in the different cancer registries, and we sent it to one central place, and they did all of the computation, calculations. That was Denmark, the Secretariat in Denmark, which did all of this. And then we sent aggregate data to IARC to put into the Nordcan database and provide the basis of the web tool. Then Gdpr came along, and it forced us to be innovative and find new ways of sharing this data. So we flipped the data flow around a little bit. We tailor-made our script, our Instata script, to do all of the calculations within the boundaries of each cancer registry. And then each of the cancer registry send aggregate data directly to IARC. So the role of the Secretariat is now to provide the specifications and the tailor-made script to do this. So we're moving towards more of a federated analysis way of doing this, which is, I think, a key point also for the future. And this was then in keeping with the GDPR rules, because we are not allowed now to share individual data with IARC, which is a huge problem, but we need to find ways to make sure that we can still keep this cooperation going. So we made this risk analysis, we made sure that we are only sharing anonymized data, and we made a huge effort to make this happen. And we made it. We now have data from until 2019 in NordCan, and we are able to share these data, so that's a big effort for us. This is just an example of the script we made. I'm not going to go through the R script here. For those interested, you can look more into it in the slides. So why did we do all of this effort and work to have NordCan up and running? We did it because it is important for cancer surveillance. I will show you 3 examples now, one from the past, one from the present, and one from the future, with examples from NordCan, where you can see this. The first example is what happened to the Danish cancer survival. If you look at this graph, you look at the purple pinkish line, you can see that for males, which this graph is showing, the survival was quite much lower in Denmark than in the other countries. You could see the same for women. You could also see the same, for instance, for lung cancer. And there's really no reason for Denmark to have a lower survival than the other Nordic countries. The Nordic countries are quite comparable. So they looked into this, the Danish society looked into this and said, okay, we can't keep like this, we need to do something about this. So introducing, for instance, standardized cancer care plans for the patients, and looking at diagnostics, looking at screening, looking at treatment options, they were able to change and now have a survival almost on the same level as the other Nordic countries. And that is one example of how you can use statistics, the basic, maybe a little bit boring statistics from the cancer registries, to make implementations, which really plays a big role. You can use also NordCan, for instance, and other, like Global Cancer Observatory that Elisabeth was mentioning, and the ESIS platform, and all of these cancer statistics. You can use it to break it down to smaller pieces to let us see the whole picture clearer. An example here for melanoma. You can see the incidence of melanoma rising quite high. This has been mentioned also earlier today by several of the speakers. And the mortality seems to be quite the same. So, okay, incidence is increasing, mortality not increasing that much. What shall we do about this? If we break it down and look at the age group 0 to 54, sorry, you can see that it's, well, the incidence is increasing quite a lot. That was maybe the previous pictures, sorry. Yeah, so if you compare age groups, you can see that the incidence is really increasing most for the oldest age group. And also mortality is increasing quite a lot for that age group. And that helps us think, okay, we need to tailor make our message to the public, to the society, some way that we can help prevent that amount of mortal melanoma cases among the oldest patients. The third example is, what can we expect in the future? This has also been brought up by several today. All of the points have been said by the other very good presentations, but I think we can repeat those. I think that's a good thing. This is predicted numbers of lung cancers in the future. Even though the risk is changing in at least some of the countries because fewer people are smoking, the numbers of lung cancer cases will still be increasing for quite a lot of time ahead, to 2030, not leveling off maybe until 2040. So we can't afford to build down the surgery units for lung cancer surgery, for instance. We need to plan to take care of these patients in the future as well. So, is cancer statistics boring and not useful? I might be preaching a little bit to the choir here, because the answer is, of course, no. Boring cancer statistics is of high importance. It is the fundament of everything we do. So we can build a fundament from the cancer statistics, and we can build a house on that that serves all of the other needs we have. But it is necessary to have cancer statistics that follow long-term trends. That's, for instance, that's necessary to predict into the future what's going to happen. It's necessary to be able to break it down, because cancer is not one disease. It's a lot of different diseases. And it differs from different regions. It differs in different genders. It differs in different ages. So we need to be able to break it down to smaller pieces to look at what's actually happening here. And pulling together data, because the Nordic countries are quite small, Sweden being the largest of the Nordic countries. But by pooling the data together, we can get a better overview, both of the trends we can compare, and we can also look at a little bit more rare cancers and see what's happening there. And from the cancer statistic, we can discover patterns that would allow us to see where do we need to dig more. Where do we need to talk to clinicians? Where do we start using clinical registries? And with that also the voice of the patient through, for instance, patient-reported outcome measures. Where do we need to do more research? And probably we need to do all of these things at the same time. But there are some challenges, and I think timeliness is a challenge that all cancer registries are very aware of and trying to solve, because it takes a lot of time to get quality assured data for a year, for instance, for all of the cancer cases. And we saw this through the COVID-19 pandemic, that we really wanted to have data ready much sooner than most of us could provide, because we were very eager to see how did the pandemic really affect cancer diagnostics and cancer treatment. So timeliness is a challenge. It's a challenge for the cancer statistics to keep it clinically relevant, because there is a little bit gap between the kind of basic cancer statistics and what is clinically relevant. So we need to work together with the clinicians and the clinical registries also to close that gap. And as I mentioned, starting, for instance, with Gdpr and other things as well, data sharing is an increasing issue. So we need to find ways that we can still pool our data together and still do all of the research and the cancer statistics that we need to do. Federated analysis is one way of solving it. There are several European initiatives like OMOP and EHDS2 and other initiatives to try to overcome this and make the very, very excellent European cancer data even more useful in the future. So we need to continue to do the ever-going work on harmonizing registration of cancer and quality assurance, discussions on inclusions, exclusions. This sounds like a little bit nerdy and specific things, but it's super important, and it has been mentioned earlier today as well, because we need to be sure that we compare apples with apples and not apples with pears, for instance. So we need to be sure that we are actually comparing the same thing. We need to use all of the tools we have, like NordCan, like GCO, like ESIS, in cancer surveillance even more actively. We need to do research. And we need to make sure that cancer societies, researchers, and others use these tools that we have with the boring cancer statistics. Because tools like this are low-hanging fruit. All of the analysis is already done. All of the graphs and tables are already made. And it should just be used for all that it's worth and more. And because this is not just the effort of the cancer registries in the Nordic countries, it's the effort of all people working together for cancer registration and also the patients. So we need to continue this cooperation to bring not only years to life, but also life to years for the patients. Thank you.
Thank you very much, Siri. We have some questions for you, so please join us at the table here. And I have a first question for you. Do you have any idea, the Nordcan system, how many different users are really using your system?
Ooh, I should have checked the statistics before I came here, but it is a lot. But it differs a little bit between different countries. Yeah.
And do you have any idea of the type of users that are really there? Do you check on it or do you list it?
We don't have statistics on different users, but I do know from kind of word of mouth that it's a lot of patients using it through, for instance, the Danish Cancer Society. They're linking to Nordcan through their fact sheets. They're using Nordcan fact sheets, actually. And I get a lot of emails from researchers wanting to use the data as well. But it should be used even more because it's a very good source of information.
Yes, it is. It is the low-hanging fruit that you are referring to, so we all know who you are referring to. And what could be the next step? Because now you say it's low-hanging fruit. Is there any other fruit that you could hang and that could be available for others? Do you have plans in it? We tried to detect it in your presentation. What could that be?
Yeah, we've spent a lot of time now, as I mentioned, to just renew everything, to make a basis of making it even more useful in the future. So it was a necessary kind of a rebuild of the house. But we don't have stage, for instance. We talked about that earlier. Yeah. So that would be a good addition. But then the issue of GDPR and sharing data is becoming more prominent because it would make the data even more detailed, making it harder to be sure that it's anonymous and that we can share it with IARC. So, but
delicate balance.
Yes, a very delicate balance. But we do have thoughts of what we would like to have in the future. We just added a few things like the estimated annual percentage change and the cumulative risk of cancer. So we're adding a few small things every now and then. And also making it a little bit easier for users to get the kind of raw data behind it. Yeah.
Okay, and that is possible for GDPR regulation too?
Yeah, it's as long as the data is anonymous and they can just download the anonymous data. But now they have to download several Excel files, for instance, to build the data that they need. So making it maybe a little more easy to get that.
So you're more aggregating the data also to avoid small cells and so GDPR is not making our lives easy because with Nordcan you're really taking care of the visibility of the cancer registry and then you're doing it with a lot of countries together in the Nordic. So that's really great. I look at my list to see, because there were other questions, how could it extend to more clinical data for the clinical registries, for example, because now you have shown the more popular epidemiologic descriptors. Yeah. What about more clinical data? What do you think?
Very interesting topic, and clinical registries are getting more and more common in the Nordic countries as well. And I think there's a huge value to getting that data as well, but it's a little bit still in the future. But as I said, it's one of the challenges to make it more clinically relevant, yes.
Like you also refer to the decentralized, or how do I have to call it, the federated approach, as you say it beautifully. I think that the Netherlands Cancer Registry is also working on that. So do you think that we could move on there also to have more data available together or more results? What do you...
Yeah, I'm hoping for that because we are discussing this very much both with IKNL and between the Nordic countries and other corporations we have. How can we use our data even more? Because that's really what the cancer registries are about. Do we do more federated analysis? Do we do synthetic data sets like the IKNL has just proven that it's possible to do? And we just need to be innovative in the future as well, I think. Yeah.
It's a plea for collaboration.
Yes.
If I'm right.
Yeah.
Thank you. Yeah. Thank you so much, Siri, for that. And I think it's a good launch for the next and to move on with our program. Thank you so much, Siri. It was very helpful. That means that we already come to a kind of last session here. And I have the honor to introduce Professor Thijs Merks, who is well known to you if you are from the Dutch part, to you as your Chief Executive Officer and Chair of your Board of Direction, and in binôme with Valerie Lemmens. It is so strong for a cancer registry, and we cannot but emphasize this, to have the guidance of and the collaboration with clinicians, and like you, Professor Thijs Merks, in maxillofacial and oral oncology. But I think that a strong bond between clinicians and cancer registries can really make things move forward. We met some months ago for an informal discussion to brainstorm on how to give visibility to our cancer registries. And there is no doubt that you will give that as a person and that you are already doing so for the Netherlands Cancer Registry. I have an important question now for the public, so you need to work up a bit now. And you should launch in the special word cloud that should become visible at your screen, to launch a word that comes up to you when you are thinking about how can data in cancer registries help us to overcome challenges. So the first word that comes up in your mind, please launch it in the word cloud. And I think that Professor Thijs Merks and the panelists will be happy to look at it and to discuss with you. So I leave my chair now to Professor Thijs Merks.
Thank you very much. What an enormous word cloud. One word actually is the most important, and that's prevention, although inside and insights are mentioned twice and is actually the same word. So inside or insights and prevention. Let's go to you. What is your first reaction on the words insight and prevention from patient perspective?
Well, thanks. What comes to mind actually is we need more prevention, we need early detection, and to achieve that, I would assume we need insight. And when I say we, I speak as an ex-patient, but also as a representative of patient organizations. I think that it's time also that we can start asking ourselves as patient organizations, what can we do to help educate citizens, the general public, so that we can increase prevention and also increase early detection.
And Robert, if you look to the clinicians, and I'm a representative of those, how can, from your opinion, from your perspective, insights help the clinician?
Well, it reminds me of once I gave a talk to clinicians, and it was a question that I asked myself before starting. And how can we do that? I think that it's good to understand the patient perspective. But again, when I say patient perspective, I'm speaking about our need to increase quality of life. I want to say as well that I do not want clinicians either to be putting themselves in the shoes of patients, because I want you to do the best job possible. So I want you to understand that when you need information, that there are resources to get information to better understand why you're doing certain work and how it can help to increase the quality of work that you're doing, so that we can benefit from that.
Before I go to the next one, one additional question, because you do not mention it, and I want to be sure that you mean it, and that's the quality of the data, because insight has always to be based on the same level of the quality of data, because if you do not have the same quality, also from national as international perspective, the same data dictionary or thesaurus, then you have no insights.
Well, my request to organizations would be to collaborate with each other. My request would also be, when collecting data, to think about the moments in time, for example, when collecting patient-reported outcomes, when the questions are being asked. If we can guarantee that the results that we get from those questionnaires, that they truly represent the patient's perspective. So two things I would request: for better collaboration. I would also request that we keep in mind that the outcomes that we receive needs to be validated, and it needs to truly give a picture of what the patient is actually feeling and what they want us to be saying as well.
Thank you very much. Siri, if we go to you. Ladies first, sorry. If you hear the answer of Robert and the questions I asked about word cloud, what is your answer, or what is your perspective on prevention, insight, and quality and continuity of data?
Very good questions. Of course, much of the same as you're saying, that through the cancer registries, for instance, we collected a lot of data that can be used, for instance, for knowledge-driven decisions for the clinicians, to help clinicians base their decisions on statistics, long-term statistics, high-quality statistics coming out of this. But we also need to think broader. As I said in my presentation, the cancer registries are the fundament, and we need to build on that with, for instance, patient-reported outcome measures, and put this together to make it even more valid. So you would get insights to treat the patient the best possible way. And for prevention, I briefly mentioned also using cancer statistics to see where is actually the issue, what can we do to tailor make our what we say to the society for prevention for melanoma, for instance. Where should we aim our measures? Yeah.
And the aspect of collaboration is also meant from international perspective.
Yes.
And you are normally cooperating with Scandinavian countries, but not with, for instance, the Netherlands Cancer Registry, or the Belgian Cancer Registry, or the French Cancer Registry. How do you see cooperation from that perspective?
I think we need to cooperate even more, because the more data we have, the stronger we will be. And there are some challenges to it. We are cooperating a little bit with the Netherlands, but
a little bit.
Yeah. So I would ask for more cooperation like that, and to build on each other's experiences and the knowledge that others have, and build us even stronger. So European and even international collaboration is key, I think, to both to be able to prevent and to treat cancer patients the best possible way in the future.
Thank you. Johann, your presentation was very clear, Dutch cancer agenda. And we talk about healthcare, but actually healthcare is very small if you see the numbers Valerie, for instance, showed us. Have we to look broader than only the Ministry of Health? Because have we looked to education? Have we looked to the Ministry of Finance, Economics, Social Affairs? So how broad actually is your national cancer agenda, and not your, but our cancer agenda? And how do you see this to make it not too big, but on more tables than only the Ministry of Health?
Yeah, it's a good point, Thijs. Although I should hasten to point out that the health budget, the health ministry, is the second largest item on the national budget, and with business as usual, it will overtake social affairs very quickly. So that in that sense, this is already a big thing, right? So health is, I think, the primary sort of systems responsible from the central government point of view. It doesn't mean top-down planning, but they are the very first ones we need on board. And maybe I can refer to the Oncode Institute, which is a fairly recent Dutch innovation. So it's not a bricks and mortar institute, it's a virtual institute. It brings together hundreds of top scientists, but it has a very important and innovative valorization function. So the institute I call bilingual, so it speaks the language of business and it speaks the language of science, so we can accelerate the findings even of basic research quickly to society and the patient. And this is, so there are three ministries investing here. So healthcare, the health ministry, economic affairs, as they also see returns coming from working together with startups and pharma, and obviously education and science. So those are the three obvious candidates to participate, which is an initiative, sort of, it's public-private, so it's 50% charity money and 50% coming from government. Although interestingly, government increasingly thinks in terms of revolving funds. So we have sunk assets, and the government wants, we want my money back.
Yeah.
That's an interesting position from government. I don't want my money back. I want societal returns back. Now, which is a different type of stakeholdership. So I'd say it does cut across the board of government, but if we start with the health ministry, it would be a very, very good start, as we would like to help them not to topple social affairs as the biggest item on the national budget.
Your answer is not clear to me if you look at from Ministry of Education. How do you see them involved?
Obviously on the research agenda. So
only from the research and not from training from high school to university to become, if you look at this moment, the capacity of healthcare cooperators and nurses, doctors. So from that perspective?
Same thing. So you're right. I was just thinking of research coordination, because there's a lot of research money available, both in the Netherlands and in the European Union, but the windows are quite separate. And we don't know about the redundancies, we don't know about the lags.
Maybe it's not clear, but here in the Netherlands we have a Ministry of Education and Research,
right.
And that's the same one.
So I was thinking of research first and foremost, but you're definitely right that the whole chain, educational chain, needs to be involved.
Valerie, if you look to the questions and the answers here, and you look at from my perspective as a clinician, and you look to my job as a OMF head and neck surgeon, on the outdoor patient clinic, on the OR, on the ward, what is your advice to me as a clinician how to take your message into my Friday practice?
I'll come to that in a minute, Thijs. Maybe first I would like to reflect on the word cloud. Me personally, today I had two objectives, two goals. First of all, I wanted to make clear the importance of patient involvement in the work that we do. Mm-hmm. Second of all, I wanted to make clear the important role that cancer registries in the Netherlands and in Europe have when it comes to prevention. And I think we have achieved today both of these goals. This afternoon, Hans Nijman told it already, it was clear that for IKNL, patient involvement is key. And looking here at this word cloud, thinking back of the presentations we heard this evening, I think nobody will doubt anymore that prevention for cancer registries is one of the key aspects to focus on in the forthcoming years. Now, you asked me about advice. I think in the current situation in society, with the COVID pandemics, with all the measures, I think there are a few things that we have learned about. One of the things that we have learned is that if there is enough pressure, we collaborate, also internationally. Second, an important lesson is that we have to rethink how we deal with healthcare in the Netherlands when it comes about the smaller getting working age population in the future and the enormous amount of elderly we have to take care of in the future. So your question, what can you do as a clinician? Please make sure that not only becoming a doctor, but becoming a nurse, working with patients becomes more attractive for young people to study, for young people to take up these jobs. We need them in the future.
So be proud on your job and help the younger generation to become a healthcare worker.
It starts with education.
Yeah. You look to Johann as...
Well, yes, but then we need more than applause once in a while, right? So then the profession, especially when it comes to the nurses and the non-medical specialized staff, so to speak. I mean, they need to earn a more decent salary, but also in terms of, I think, societal appreciation. They need to move up the ladder. And I don't know what we've done in the country the last 10 or 15 years, but all these pivotal roles, the teachers, the policemen, the nurses, you know, we didn't treat them in the way they deserve to be treated. And I really think that needs a system change. And, you know, because we can talk about it in nice and whatever, but we need to pay them well, they need good career perspectives, and we need to appreciate their jobs much better than we currently do. And not only in the middle of a pandemic.
And I think COVID is a good kick in the butt.
It is.
But we have to keep kicking butts in the next few years.
Well, we will.
Siri, if I look to the word cloud additionally, prevention, and it's not quite different in the Nordic countries, I presume. How do you look to the impact on the prevention agenda in the Nordic countries? And do you have in the Nordic countries a comparable cancer agenda? Or is there Norwegian, Swedish, Finnish, Danish, separate cancer? Do you have, how is it organized? And what is your perspective if you hear the voice of the head of the European Committee, Van der Leyen?
I don't know all of the cancer plans in the Nordic countries by heart, but there's a very good cooperation both between the cancer registries and the cancer unions in the different Nordic countries. So they work very closely together, and the Nordic cancer unions also work closely together with the Association of Nordic Cancer Registries. So we are trying to pull at the same threads and make a joint effort to, because we can't live without each other. It's cancer societies need the research and the data from the cancer registries, and the cancer registries need the cancer societies to provide the direction and the patient voice and everything into this. So I think it's quite comparable between the Nordic countries, but of course some differences always exist.
So you're not asked for input in the separate national cancer agendas by the call of von der Leyen and the Commissioner of Health from a European Committee?
Actually, I don't know. Oh. I could check that, of course.
Okay,
but yeah.
And so that makes the shift to Robert. Robert, you are a representative of the European cancer patients. So do you have any information for us how in Europe the patients are allied to or informed about the separate national cancer agendas? And do you have, from patient perspective, a cooperation with each other? Because you were this cooperation, but I bounce it now to you.
Okay, that's a good question. I'll give you my opinion on that. First of all, collaboration. I am an advocate for collaboration. And when I say collaboration, I mean between patient organizations as well, across the board. We lack that. We do not collaborate enough with each other. We talk about prevention and early detection. Prevention means reaching out to the citizens. Early detection means as well reaching out to the citizens. What I often mention and talk about is the fact that we organize a lot of events, patient-related events with a whole lot of data, but we're talking to patients. And what I would love to see patient organizations do is reach out to citizens. The data, the statistics that we have the experience of what it is like and the impact that having cancer has on our lives. So I'm sure that there's more we can do to also motivate the citizens to work harder when it comes to prevention, and also educate them on early detection, what is necessary to detect cancer at an earlier stage.
May I challenge you?
Of course.
If you go back tomorrow to your job, being an advocate on the European Cancer Patients Organization, what is your personal take-home message from this evening, and how are you going to advocate this evening with all the messages from the persons here on the table?
Well, I don't think that I'll have to leave this evening and then bring across a message. Most people who knows me know that I'm not the easiest when it comes to advocating what I believe in. But definitely a message, a question I would ask is, what can we do as the European Cancer Patient Coalition and all the other organizations that I'm affiliated with? What can we do to motivate, stimulate, and facilitate collaboration between organizations? That will be my question.
Yeah. Okay, that's a nice challenge for yourself and for us as well. Last question to Johann as Dutch Cancer Foundation chairing and looking to the national cancer agenda. You mentioned a few key points and a few challenges. How do you think that we as Dutch Cancer Patient Federation and IKNL can reach these endpoints, and how the partners in crime, sometimes called, as well as the parties to cooperate with, can help us? So what is the perspective in time and in moment for us?
Writing the plan itself is not so complex, right? So if you get the right people in a room and you feed them and give them a drink and you keep them in there for a week or two, you have a great plan. Literally hundreds of cancer control plans have been written in the Nordic countries, in the UK, in France, in Cyprus. We have done it before. The thing is the whole journey. The journey is, in a way, the end. It's like what you tell your children if you go to the south of France. You say, hang on, you know, our vacation has started when we have left home. This is the same story. So we actually need the engagement of stakeholders. And I've made a desperate plea for government to come on board the moment that they have their cabinet fixed, and no day later. Also for democratic reasons, because obviously Parliament is the highest democratic organ in our country still, and has actually asked the minister, with 150 votes in favor, to draft that plan with us, with no further ado, and then work with stakeholders to find the smartest possible solutions. Because sort of the individual parts of the whole cancer mechanism in the Netherlands are excellent. But making the whole machinery work so that we can actually rise and win that Olympic medal, the Olympic medal of cancer control, we need that cooperation, we need that journey, and we need the engagement of everyone involved.
Thanks for your answer, and we are aware of the big challenge we have together, and it was a nice forum discussion. Thank you to have you here on this table. Thank you for the answers, thank you for the discussion. And I give the work back to Lisbeth, our famous chairperson this evening. You did a marvelous job.
Thank you very much. We are coming to an end, and I make a short wrap-up with you. Cancer registries see their role more and more extended. I think that this evening was a perfect example of that. We are producing data about the current status. We show improving survival rates, which is hopeful. But we also draw the attention to the future and the growing numbers of patients to treat, but also to care for afterwards. And that number is growing. We need to invest in prevention on all sides, primary, secondary, and tertiary prevention, to avoid the negative effects for the patients. We have to develop vision on short, but certainly also on middle and long term. We can do that driven by a cancer agenda, as was nicely set out, installed through the world, and through the word collaboration. I think that the tripartite that was presented today with patients' organization, Dutch Cancer Society, and the Netherlands Comprehensive Cancer Center, that they will do a huge job. But not only within the Netherlands, but reaching out the hands outside the borders, and for example also with Belgium, maybe. Even move on with patient-anticipated outcome measures, which we have heard today. Let's listen to it and always take our patient with a central view and in a central position, because that matters. I want to thank you all, to all the speakers, the panelists, for having shared your thoughts with us and to bring forward the role of the cancer registries. I think that this evening was a perfect example also of visibility for cancer registries. And when hearing the numbers of people participating, I think that this is clear. We are so grateful to the speakers, and also the stress that you face within a specific presentation here, to speak to your public even when they are in space. Thank you very much to all the participants, and maybe also some patients that have participated, because your presence means that we have some objectives in common and that we are moving on for further cancer control. And again, I repeat, and I heard from Siri also today, that repetition is sometimes not so bad, always taking the patient as a central guide in this work. Thank you for an inspiring evening to all of you. Oh yes, my question. I promised to answer you why the Belgian girl was here. I think because she knows that you are really the very best in the Dutch Cancer Center. I think I can hand over to you, Tess, for the final countdown. So thank you very much and good evening.
The final countdown, very short. You're here before you are the best chairperson we have ever had on an international symposium, with your sparkling eyes, your very subtle questions, and your inspiring conversation. Thank you, thank you, thank you very much. It asks for more cooperation.
Okay. With pleasure.